So Leo has a very impressive educational history. He did his bachelor's degree at the University of California, Berkeley, and then an MD PhD at my own alma mater, Washington University. It's dangerous to have the University of Washington and Washington University on your CV because there's no way anyone is ever going to get it straight on a regular basis. He worked with a very famous scientist there, Gene Johnson, and published some very nice work. And then, I had forgotten this, he did his internship here at the University of Washington, where he acquired an insatiable appetite for salmon, which is ultimately which brought him back to us. He left briefly to go back to St. Louis to do his residency in neurology, and then stayed on to do a very powerful neuromuscular fellowship there with some of the best people in the country, if not the world. And then sometime around probably 2010, he was attracted back to a position. We had neuromuscular disease here, and we had Leo out, was very, very impressed. And here's where the question comes, Leo. You told us a terrific story about NMDA antibodies, and I've been waiting for that paper to come out. And it's never come out. So you can address that in just a minute. So Leo's done a number of very important things here, but what I want to focus on very briefly is his role in, I would say, a continuous process of improvement of our Grand Round series. There's a lot of ways that he's improved it. I just want to point out three things, if I can remember them. Well, one is that he's given us some really memorable Grand Rounds himself. For example, and many of you had dreams about this, cannibals, mad cows, and zombie proteins. So thank you for that, Leo. The other thing he's tried to do, and I think with some success, is to recreate a culture of importance around Grand Rounds. He and I remember from Washington University that Grand Rounds was really a communal thing. There's some geographic advantages that people have in St. Louis that we don't enjoy. But Leo, congratulations. I think you recreated some of that cultural spirit. And thirdly, he's brought in terrific people. So it's going to be, I think, for the next wave of people running Grand Rounds to maintain this excellent schedule of people that he has brought in for Grand Rounds. So I got kind of sad thinking I'm going to be saying goodbye to Leo as the Grand Rounds convener. Then I thought, I have executive privilege. So what I'd like to do now is get kind of a straw vote. All of you in the audience who would like to make Leo the perpetual convener of Grand Rounds, please raise your hand. Okay, Leo, I don't need to count. I don't need any help here doing the counting because clearly, they love you. Leo, I want you to think about that tonight. Don't make any quick decisions. So Leo's going to talk to us today about death, dignity, and big data. That's kind of scary. Thank you.
Thanks, Bruce. Thanks a lot. I am very grateful to be here. It was just such a great opportunity to be at a great institute, and also just where I consider one of the most beautiful cities on earth. And I'm really grateful to be here and to be here in the department. And as I've been traveling around, I went to Arkansas and Indiana, and I really come to appreciate the Department of Neurology. And I have had great support and great friends here. Eric Krause, Dr. Ransom, Michael Weiss, James Those have always been really helpful and supportive, and that's been great, and I really appreciate what I have here. And I just want to say a few words about Grand Rounds and its organization. It's been a great partnership with Sumi and Jared, and it's been really fun, and I know that our time here is up, and I'm looking forward to the next meeting.
There's another chance.
It's great to see new blood and different approaches and to learn new things, so I'm really excited about that. And also I just wanted to make sure that people know that the Grand Rounds has been running really well how smoothly they've done the work. And so I really appreciate their help.
So a round of applause for Leo and Sumi.
All right, so today I'm going to talk about what we've been working on here at the University of Washington, and it's something that we were working on with a lot of people in the Seattle region. Michael Elliott is here, and he's been one of our collaborators, and it's really great to have all these friendships and collaborators. And so the title of my talk is once again, I like titles with three things in them. So it's Deaf, Dignity, Big Data, using analytics to improve end-of-life care in ALS. My disclosures, within the last 12 months, I've received research funding from SCORE, but that has no relationship to what I'm talking about today. I have some funding from the NIH Wellstone Center grant. I've applied for and received unrestricted educational grants from Walgreens Infusion Services and New Factor Specialty Pharmacy. I just want to make sure that everybody knows in this transparency. And I don't think anything has any relevance to what I'm talking about today, but I think you guys should know this. So what is ALS? ALS is amyotrophic lateral sclerosis. It's a progressive upper and or lower motor neuron degeneration, not otherwise explained. The incidence is about 5 out of 100,000, maybe a little bit in that range, probably 1 to 8. Greater than 90% of it's sporadic. It's known to cluster. The diagnosis is mainly clinical, but is aided by EMG. The treatments are riluzole, PEG tube placements, and non-invasive ventilation. The disease is named after Lou Gehrig, and Lou Gehrig was a New York Yankee. He was a Yankee for 14 seasons. And he started in 1928, and his last full season was in 1938. And during that season, he started to notice some problems with his ability to move in his lower body and midway point. But you really can't see that in his batting average. His batting average was actually pretty good and didn't dip in the second half. However, it was definitely lower than, it was the lowest batting average that he had. The blue line is his batting average since his rookie year. He hit about 298 that season. That was the lowest. But his home run average, he was not hitting for power, so his home run was decreased. And on the next season, on April 29th, 1939, that was when he had his last hit. He went up the day after and had no hits 4 times up, and there were men on board. And 2 days later, on May 2nd, 1939, that's when he basically benched himself and ended this streak of consecutive games of 2,130 games that he ended. And that was really what was formed his reputation as Iron Horse. He then went to Mayo Clinic and got diagnosed as amyotrophic lateral sclerosis. 2 years later, at the age of 39, in 1949, he passed away. And I thought that this was a good description of a disease, not only just for him, but also for the disease. And that's what I was hoping to accomplish in this talk, to use data to kind of understand what's going on at a population level, but also what's going on at an individual level. In terms of what can we use population data to explain or predict what's going to happen on an individual level. And I think that baseball is great in that it's able to use big data. And I was hoping that we could do that a little bit more in neuromuscular diseases. And that's what I was hoping to accomplish. So my goals for this talk are, in the first inning, I want to talk about paraneoplastic testing in the University of Washington ALS cohort. The fourth inning is going to talk about riluzole exposure and this PROACT database, this database of a lot of patients. And in the seventh inning stretch is going to be a 6-month mortality prediction model based on the PROACT database. And our last section in the ninth inning, our final inning, we're going to talk about the Washington and Oregon Deaf with Dignity ALS cohort. So the two sources of data that I'm going to be deriving our information from is the University of Washington MDA ALS Clinic, as well as the PROACT database. So what is the PROACT database? The PROACT database is the pooled resource open access ALS clinical trials database. It's organized by Prize for Life. There's 8,635 subject records. It's based on 17 phase 2 and phase 3 clinical trials that include the 3 pivotal riluzole trials. It collects demographic, lab, medical, and family history information, and it has over 8 million longitudinally collected data points. So what does the PROACT database teach us about our disease and teach us about ALS? First, here is the age histogram of patients that were in the in the PROACT database. On the x-axis is ages from 20 to 90, and here's on the y-axis the frequency. You can see that the median age is about 60 to 70, so there's a peak around there. It trails off as you grow a little bit older, and then there's stragglers that's coming through here, and then there's patients that started about the age 20, and there are definitely younger patients, and probably a lot more of those are familial forms. What are some other things it teaches us? It tells us that 60% of the patients are male and 40% are female. Vulvar onset, patients that have problems initially was their breathing or their swallowing, is 25% of the patients. 75% of them are limb onset. The database tells us that there is a difference in prognosis in terms of survival for the two types. The two different types are the limb onset versus the vulvar onset once again, and this is looking at, in the database, it's looking at the last known observation or when they passed away. This is the survival fraction. You can see that the red line, which is the vulvar onset patients, are patients who pass away sooner. So if you have a vulvar onset form, you pass away sooner than the limb onset form. All right, so going on to our first question. And inning number 1 is, should one order paraneoplastic antibody testing as part of the diagnostic process? So this was work done with Najwa Abustani, our neuromuscle fellow, who's been with us for 2 years, and she's been great, and we've been very fortunate to have her. So the usual diagnostic tests that we do for ALS are EMG nerve conduction study, a serum copper, vitamin B12. We sometimes look for anti-GM1 antibodies for multifocal motor neuropathy, there's a lower motor neuron disease. And we also look at an MRI of the brain and spine, especially if it's just limb onset disease. So what is the Mayo paraneoplastic?
Why do you order a copper?
Because copper can cause a myelopathy that can mimic vitamin B12 deficiency as well as a motor-only disease. So the question was, why do we order a serum copper? A Mayo paraneoplastic panel looks for antibodies against CNS and PNS targets. It's a sign of an autoimmune condition, and people get excited because that's a condition that you can treat with immunosuppression. So what we did was we did a retrospective chart review. There were 315 patients with motor neuron disease in our clinic. This was between 2007 and 2014. This is at the MD ALS clinic at the University of Washington. And very excitingly, this was just accepted for publication, and it's my first senior author paper, so it's really exciting. So what we found was 139 patients with Mayo paraneoplastic antibody panels. Here's how it's divided up. 176 of our patients were untested, and less than half, about 139 patients were tested. 127 of them had negative tests. 12 of the patients had positive tests, and that accounts for 4% of the total patient population. So what do we know more about these patients? So here is the age histogram of our patients, all our patients in the ALS clinics since 2007. You can see once again there's probably a peak around 60 and 70. There's a short tail towards the older age. And the red ones are the patients who were tested for paraneoplastic antibodies, and so you can see that it's a pretty random distribution. It's pretty similar to the total population. The maroon colored ones are the ones that were positive for the antibodies. And you can see it's also randomly distributed. So characteristics of our patients, 80% of them fulfill the LS-Corial criteria for motor neuron disease. 20% of them have suspected motor neuron disease. Once again, about 60% of the patients were male and 41% of the patients were female. So what were the antibodies? The antibodies that were positive, 4 patients had voltage-gated calcium channel antibodies, 4 patients had striated muscle antibodies, 3 patients had voltage-gated potassium channel antibodies, and 3 patients had GAD65 antibody positive. And then 2 of them had acetylcholine ganglionic receptor antibodies. These antibodies are the antibodies that we commonly see in our patient population if we go and test for paraneoplastic diseases. And based on an Athena paper, Athena poster, they found that these were similar antibodies that were positive. And so, how many of these were tested for further tested for occult malignancies? And there were quite a few of them, but not all of them did. What we found was we searched for occult malignancies in 9 patients, and it was for naught. There was 1 patient who had GAT65 positivity, and that was not only in the serum, but it was also in the CSF. And they were treated with IVIG and steroids, and there was no change in the disease course. She passed away. None of them had a different disease course than what is expected. So our conclusion is that unless the patient presents with atypical signs of ALS, was probably, if it's not just purely motor or frontal temporal dementia, but there are other signs in terms of maybe ataxia or autonomic problems, we probably don't need to send off the test, and we can save on the money. It's a fairly expensive test, and that this probably does not add to our diagnostic value in terms of for the patient.
How expensive?
I believe it's about $500 per test. So in inning 4, we're going to ask the question of, does riluzole work? So what is riluzole? Riluzole preferentially blocks the tetrodotoxin-sensitive sodium channel, reduces glutamate-mediated excitotoxicity. It's the only FDA-approved drug for treatment of ALS, and it's also one of the medications that the AAN recommends that we give to our patient. Even with those recommendations, there's a recognition that it has a very modest benefit. There's a slight improvement in survival, but there's no improvement in strength. And their side effects include nausea and rare hepatitis. Here's the data from the 3 pivotal clinical trials that was used to approve riluzole by the FDA. And there were 1,282 patients. The red line is the patients who were treated. The blue line are the patients who received placebo. And this is a combination of the three different trials. And they found a difference, statistical difference at 12 months, also at 18 months. There was a difference between the two at the 2 different time points. And the thought was that riluzole improved survival by 3 months. And that was how it got approved. However, even in the FDA analysis of the drug itself, in the IND, it talks about how some of these curves, I think this one and this one, they start to merge together, and there's concern that maybe even taking the medication would accelerate the disease. I don't think that's true, but there was definitely that thought. So the question remains, how useful is riluzole? And so we thought that we would try to answer that. This is a project that I did with John Nave, who was here at University of Washington. It was to look at the PROACT database. There was data on patients before they enrolled in a trial, and then there was data on when they enrolled in a trial to their last visit or the time to death or last ALS, FRS visit. And we were trying to look at these patients and trying to look at the patients who were exposed to riluzole and those who were not exposed to riluzole. So here is a breakdown of the patients. There's 8,635 patients in the database, 7,108 patients who had known exposure to riluzole. Of those, we know that 25 patients passed away during the study. 254 survived to the end of the study, and 4,429 we did not know whether they survived at the end of the study. Then that's probably based more on how it was coded in the database. They probably all survived, but it's hard to definitively say that. We excluded some patients who had no time of death, where they had no end of study evaluation, so we don't know when their last study visit was. Of those, we were able to collect 4,870 patients. So what's robust about this study is that there's a lot of patients. And we had, and all these patients, the 4,870, we knew that their survival status at the end of this study, and we know about their ALS-FRS, the functional rating scale. So that's a scale that's been developed to follow patients' function throughout the disease, and it's been used to follow function in clinical studies. And we use that, since it was been used a lot in the clinical trials, we use that as the last endpoint, which we received a functional rating scale as your last known observed date. So here's what the data showed, a breakdown of the 4,870 patients. So 74% of them had exposure to riluzole, so 3,582 patients versus 1,288 patients, 26% had no exposure to riluzole. There were no differences really in the median age of the patients. They were both 57, 58. The number of patients who were male were both 61%, and bulbar onset was in the range of 22 to 24%. So those, their starting characteristics, these were the ones that were similar. The things that were different was duration of symptoms. So the patients who were exposed to riluzole had longer disease. They had disease for 671 days versus 608 days for the patients who had no riluzole. The average ALS FRS, the functional ratings score at the beginning, was 30.3 for the patients exposed to riluzole and 31.1 for those who were not exposed to riluzole. This was statistically significant, but a difference of less than 1 point is probably not clinically different. However, their score at the end of the studies was 21.2 in both cases, so that was no different. And the change per month of score was really no difference. For the number of patients in different study arms, in terms of placebo versus active, a lot of patients in riluzole were, a lot more of them were in active trials, while if you were not exposed to riluzole, it was less. And this probably reflects the fact that we're including the 3 pivotal riluzole trials in there. So here's once again the age distribution of the patients in the PROACT database. That's all of them here. And these are the patients that were exposed to riluzole, the red ones. And so the red ones, you can see it's, once again, it's a pretty random distribution of the two. And so here's what we see in terms of survival fraction. In terms of the black line is patients who are not exposed to riluzole, and the red line is patients who were exposed to riluzole. And this is looking at the time to their last visit or the time to their known passing away. And what we find is this is uncorrected for covariance. Is that it seems as though if you took riluzole, you pass away a little bit sooner. Now, if you take into account age, gender, bulbar onset, and duration of disease, that difference seems to be not statistically different. That's something that John and I are still working on. But it seems the data suggests that right now, if we just look at just purely in the database, that there is a difference between riluzole and between not taking riluzole and taking riluzole. So this is just looking at survival, just looking at patients who passed away. There's another fancier way of looking at survival as well as function, and that's using a fancy statistical ways of just ranking patients based on patients that were the best to the patients that were the worst, and you rank all of them based, including survival and as well as function. So if you do that, if you do a combined survival and functional rank sum analysis, and you do a Coxing analysis based on the rank, you see that the median rank of the patients that were exposed to riluzole versus not exposed to riluzole were basically the same. There was no statistical difference. And this suggests that if you rank them based on how well they were doing, function as well as survival, there was really no difference between the two. So this is another way of just looking at survival function and whether riluzole as a variable changes that. So the conclusion that we came to was riluzole may not add to the quantity or quality of life of our patients, and better medications are needed, and that's really clear. And that's what the Ice Bucket Challenge is doing, and that's what Dr. Weiss is doing with his Exilitin trial.
Can I ask you a question?
Yeah.
So my recollection is in the early riluzole studies, it began to be said that maybe it worked best in people with bulbar onset. Am I correct about that?
So that was some of the initial data, but I think that when they looked at larger data sets, they didn't see that.
So my question is it possible that the people who took riluzole had worse disease than those that didn't? That's that's why they took riluzole. So the two cohorts are not the same in terms of the severity of their disease to begin with.
Right. So the hope is that the question is why is there alternative explanations to why this study does not show that riluzole is working. And so if we go back to looking at the patients, the number of patients who had bowler onset was basically similar. And you would think that all of these trials are pretty similar, and you would think that they would randomize the patients similarly. And so you hope that all the patients are randomized similarly, and that over a large database that the differences will equalize. I think that looking at the functional rating scale, I think that to me that's pretty clinically significant. The difference of less than 1 point is really not that different. So I think that there's enough data here that says that bulbar onset is not that big of a difference in the two groups, as well as the function of how they started. Now, there's a difference in duration of the disease. Patients who had riluzole definitely had the disease for a longer period of time, about 2 months more. So that there are definitely differences, and that's the limitations of a study like this when you're doing like a post-market phase 4 kind of study, where you're really looking at patients that you really haven't randomized.
So is that the duration of disease up to the point they started taking the medication?
Yes, that's up to the point that they enrolled in the trial. So it's not, the database doesn't tell you how long they took riluzole, whether they continued to take riluzole throughout the time period.
Yeah, question for you. So riluzole is also thought to maintain patients into earlier stages of the disease for a longer period of time. There's a way to look at this PROACT and try to tease that information out. Maybe looking changes in the ALS-FRS-R score, maybe looking at patients who have greater than score 25. How long versus those less than 20. I don't know. There must be a way to do that. Try to prove that or disprove that claim.
So the question is can you use this database to see if whether it helps patients earlier in the disease? And one way you could do it is by looking at patients with a baseline functional rating score that's higher. And I think you can do that, but the problem is that you're dividing the group into smaller and smaller groups, and I feel as though it's just dangerous, especially when you already have problems like what Dr. Bird talked about in terms of randomization. I think that the points that I would get out of a study like this when it's really dirty, based on a very dirty database, is you wanted to not overstate conclusions. Try to do simple conclusions based on as big a population as you can. So that was our thoughts.
What about other data like force vital capacity going in during? Is that data available?
That data. So in terms of looking at force vital capacity, that data is available. It's not. Yeah, it is available, and you can definitely look at that. It's probably going to be another subset of patients, but that definitely is something to look at because
it's such a determinant of survival that I wonder about that as well.
Yeah.
Leo, it's obvious that this drug has a marginal benefit, if any benefit. So that's just the starting point. The only part of this conversation that's interesting anymore, I think, is whether or not those 3 months, if you believe in them, are quality months. Right? This is not a very nice disease. And usually the end stages of this disease, when they stop coming to see the doctor, are pretty awful, pretty miserable. Has anyone made an effort to see whether or not extending life with this miserable disease, actually extends the quality of existence?
I don't think they have. Do you guys?
I think based on the mechanism of action, what I tell people is that the benefit is conferred throughout the duration that you're taking the medication, not at the very end, not at the beginning, but throughout the duration. Now, I have no basis other than theoretic to say that, and so I sort of liken it to stretching a piece of taffy. The whole piece of taffy gets stretched, the whole life duration of the disease gets stretched, not just one end or the other. But I don't know that anybody's ever studied that.
No, I don't think so.
No, I don't think so. I think quality of life measures still get embedded for ALS, so they haven't really.
I mean, frankly, the few anecdotes that I personally have been people who said, take that medicine away. I have no interest in taking this medicine.
We'll have some data to show that.
The sad thing is, other things like non-invasive ventilation probably extend life. They extend life up to a year. Some say just up to a year. So a lot more than.
Lately,
Probably everybody knows the answer, but I don't. I assume Luluzol is offered for anybody who comes with diagnosis. So how the conclusion decision between patient and physician that we have this reason?
what's sorry?
There no in all those studies. Yeah. Those are all retroactive.
So 1,200 patients were patients who were enrolled in the Riluzole trial.
Just
So they there was placebo versus Riluzole, and then there were a couple of trials in which it was basically Riluzole plus something and then something plus nothing, and
so
so
they were randomized into
Yeah.
either
they were randomized. All right, so the seventh innings, we're in the seventh inning stretch. Can we predict better when patients will qualify for hospice? So the question of when a patient qualifies for hospice is usually when we say that it's about when your FVC, your forced vital capacity, is about 50%. And I asked Dr. Bendit, like, where's that data from? And he pointed me to the Stambler paper, which is based on one of the clinical trials, also in the PROACT database. In that database, you can see here what in that treatment trial, what you can see here is time to death. This is time before prior to death, and here is 0 is when you die, and this is 5 months and 10 months. This is FVC, and you can see that over time it decreases. The FVC does decrease, but where the 50 mark really isn't 6 months. It's in this kind of area between 6 and 10 months. And so the question was, what does the PROACT database say? Does that rule fit in terms of if your FVC is less than 50, does that mean that you're going to die in 6 months? So when I went and plotted all the FVCs of the patients that we know and how many days before they died on the x-axis, the 0 is when they passed away, and this is 200 days before they passed away. This is percent FVC predicted, going from 0 to 100%. You can see it's basically a random cloud. So on day 0, like 1 or day 0 before you pass away, your FVC could be from bottom here, which is probably like 8%, to about 80%. So it's really hard to predict whether you're gonna. It's hard to say that 50% really is gonna predict whether you're gonna pass away in 6 months. Now, if you take the average of each day throughout this whole time course, you can see that it does curve down. That the average of each day, each of these red circles represents the average of the FVC per day. You can see that it does curve downwards, it does decrease. So the average FVC does decrease for each day. Now, in terms of how good it is, 50% is predictor of when you pass away. If you have an FVC of less than 50%, you have a 53% chance of dying within 6 months. This is based on the PROACT database. However, this picks up only 43% of patients who passed away. So the question that I wanted to ask was, can one develop a better predictive score to help distinguish those who qualify for hospice or death with dignity that expounds on the FVC, that can use, based on the FVC, can we do something better and help our patients predict when they qualify for hospice? So we looked at 15,591 visits. This collected from 2,278 subjects. Each visit was coded as whether you died or you survived at 6 months after the visit. So we found that FVC was a prognostic factor. Here in the blue are patients who survived, and their FVC is probably centered around 80 to 90. If you passed away, your FVC was probably around 50 or lower, but there was huge overlap in terms of those who survived in those who passed away. And the question is, can we come up with something better? Can we come up with some simple prognostic factors that we use in the clinic to try to separate the two and try to distinguish those who passed away versus those who died? So some of the factors that we looked at are age. Age seems to be predictive whether you're going to pass away or not. If you have older age, you're going to pass away more than if you a younger age. So that was one thing that helped. BMI in terms of weight, that seems to be something that we tell our patients that weight might be something that's protective. The higher weight you have, it's protective against whether you survive the disease for longer. So here on the x-axis is the BMI, and it goes from 15 to about 40. And on the y-axis is the density. You can see that there's a pretty big overlap between those patients who died versus those patients who survived. However, there is still some way that you can pull them apart and distinguish the two. Looking at ALS-FRS, the functional rating score, you can see that there is a difference. The patients who survive versus the patients who passed away, that there is some overlap, but you are able to kind of distinguish those patients who died versus those who survived. But the things that we found that seem to be more useful is change. So change in ALS-FRS, if you just look at change compared to their first visit in clinic. So here is if there was no change in their ALS-FRS compared to day 0 when they first enrolled in the study, versus if you can see that if your ALS-FRS decreases much more, the chances that you're dying is higher. Similar to weight, if the more that you have a change in weight, the increased chance of you passing away. If you had change in FVC that was larger, the chance of you passing away was larger. And so the question is, can we come up with an ALS hospice index, a scoring system that is simple, that's kind of like what the residents are using for determining how to anticoagulate patients with atrial fibrillation, a CHA2DS2-VASc score. And I thought that would be really cool if we could do something like that. And one of the things that we would include in this score would be age, BMI, change in weight compared to your first visit, FVC and your change in FVC, whether you're bulbar onset ALS-FRSR and change in ALS-FRSR. So if you come up with a scoring system, and this is still preliminary data, if you come up with a scoring system, you can try to distinguish and pull apart those patients who died versus those who survived. And this is just a preliminary, just back of the envelope calculation. And you can kind of separate out the two. Now, based on this scoring system, it's really preliminary. If you come up with a score of greater than 19, then you have a 75% chance of passing away in 6 months. However, this only picks up 14% of patients. If you score greater than 16, you have a 70% chance of passing away, and it covers about 24 patients. Now, if you lower this threshold, your chance of passing away decreases, but it picks up more patients who pass away. So that's, once again, you're sacrificing sensitivity for specificity. You're sacrificing specificity for sensitivity. So the things that we want to do in our clinic, and I've been talking to people at UCSF and Arkansas, and hopefully Dr. Elliott will help us out, is that was really interesting, and that's based on a population of patients between 1990s and 2014 at the PROACT database, and does it really work in the clinic? Does it really work in the present day? And I think that the things we want to test out are age, BMI, change in weight, FVC, change in FVC, whether they're bulbar onset, the ALS-FRSR score, and the change in ALS-FRSR, whether they have a flare arm or flail leg variant, and neck extensor weakness. And whether that, collecting the data and seeing whether they survive in 6 months, and trying to compare that to those who survive and those who did not survive, and trying to come up to see how important are these and whether they can be weighted in a different way to help predict better when our patients will be hospice candidates. And I think that one thing that somebody mentioned that we're going to try to incorporate is also just comparing to our clinician's impression. Maybe we don't need this fancy dancy score if the clinician is better than the score. And so we're going to try to compare it to the clinician impression of prognosis, of whether they think that there's a poor prognosis in 6 months or there's a good prognosis in 6 months. So that's the kind of thing that we would like to test out in our clinic. All right, so now we're heading to the last final inning, and it might be controversial, but I survived Arkansas and Indiana, so I should be fine here. that was part of my religious freedom restoration tour, and somehow I was able to survive that. So I'm going to talk about the physician-assisted suicide in Oregon and Washington patients with ALS. So the Oregon Death with Dignity Act was passed by referendum in 1994, and it was enacted in 1997. So what happened was the people voted for the referendum. The state legislature disagreed with it, came up with a lot of lawsuits and a lot of different laws to inhibit the prosecution of the law. They put a new referendum in to try to repeal the referendum in 1997. That failed miserably. Failed by a vote of 60 to 40. 60% of Oregonians decided that this was a good thing. And it passed in 1997, and they started in 1997. In 2006, there was a case. The case was in front of the Supreme Court of the United States. It was Gonzalez versus the United States. And in that court case, they decided that each state had the right to experiment to determine what was right for them and what was the best way to treat their patients, and that the United States government could not use the Federal Controlled Substance Act to prevent physicians from helping their patients. So that was confirmed in 2006. The Washington Death with Dignity Act was Initiative 1000. It was modeled after the Oregon law. It was passed in November 2008. It went into effect in March 2009. Allows terminally ill adults seeking to end their life to request lethal doses of medication. They must be a Washington state resident and have less than 6 months to live. And these are basically the same rules as it is in Oregon. So the Washington and Oregon ALS Death with Dignity cohort. The Washington cohort is a collaboration of 3 tertiary care centers: Swedish Medical Center, Virginia Mason Medical Center, and the University of Washington Medical Center. Our 3 centers cover about 4 million people in the Puget Sound area and 7 million people in the Washington area, and we have 39 patients with ALS that we were able to collect. We also obtained data from the Oregon Health Authority on 71 patients with ALS who actually used the medication. So in terms of the characteristics of patients, we're comparing it to the total Washington Oregon cohort, which has 1,876 patients. We have a total of 110 ALS patients. That's about 8% of the population. You can see that in terms of male, non-Hispanic, white, married in college or above, they're very, very similar to the statewide all-cause population. There is a slight difference in terms of male. It's 59% of the ALS population. The ALS cohort was male, and that's probably reflective of the fact that there's a predominant male ratio in ALS patients. All of them were white, and most of them were non-Hispanic white. A lot more were married, and mostly everybody had college or above, and that's pretty similar to the rest of the population. In terms of the characteristics of the patients, in terms of when they died, you can see here's the histogram. This is 18 to 14 to the age range of 85 on the x-axis, and this is the distribution by percentage. So the red bar here is basically the distribution of patients who died in Oregon and Washington. And you can see once again there's a peak around 65 and 74. And compared to the total cohort, the all-cause cohort, there's a shift to the left, a shift towards younger patients. And that's probably reflective of the patient population that we see with ALS. As a total cohort, most of them are oncology patients, and therefore they're a little bit older. In terms of the characteristics of the Washington ALS patients, we're looking at basically the time from when they were born to when they have symptom onset, from symptom onset to when they have requested a prescription, and from when they have prescription to when they pass away. So this is the data for the Washington cohort, 39 patients. The age of onset was 64, was a range of 42 to 83. The days between symptom onset and prescription was 712 days. There's a huge range between 207 and 2407. In terms of days between prescription and death was 22 days, and there's a huge range. So it's 0 to 386. And you'll notice that 386 is way beyond the 180, the 6 months value that we asked for. That was really few. There were really few patients who had that, but definitely we are failing in correctly predicting whether patients pass away within 6 months. This is the data for our cohort of 39 patients. The cohort of the Oregon patients, it was 52 was the median days between prescription and death. And the range was 0 to 600 for their population. So a little bit more about our population. 31% of them had bulbar onset. By the time they requested a prescription, it was 92%. 82% of them had dysarthria, 82% of them had dysphagia, 36% of them had peg tube placement. 89% of them, most of them had dyspnea, and 53% had BiPAP use. Limb involvement was in 100% by the time you requested medication. Motorized wheelchair use was in 42% of patients. And really, all use was not as much. It was 34% of the time you asked through prescription. What are some other information about our Washington cohort? This is looking at the earliest visit and the latest visit. If we look at the ALS-FRSR, it's out of 48. The earliest visit was 34, and the higher the score, the better. By the time they requested medication, it was down to 20. The FVC went from about 83% median to 39%, so it was definitely lower than 50% required for hospice. One of the criteria for hospice. The weight, the median of the weight decreased about 13% from 176 pounds to 152 pounds. In terms of how many patients use medications, this is what we found from our patients. It's about 81% of our patients use medication. For the all-cause cohort in Washington, Oregon, it's a little bit lower at 70%. So there are definitely patients who don't use the medication, and our cohort is 20%. It's greater in the oncology cohort and greater in the overall cohort, but it makes sense that a lot of patients use this as a way to just make sure that they have autonomy, that they have control over when they pass away, but they don't necessarily feel the need to do that all the time, and some of them pass away naturally. Well, what we found that was interesting was that 56% of our patients were not religious. If we looked at the reasons why they chose to enroll in the Death with Dignity program in the state of Washington, these are based on surveys of physicians who prescribe the medications. Loss of autonomy, decrease in enjoyable activities, and loss of dignities were the main concerns. In terms of inadequate pain control, financial costs, and loss of control over body were the least important factors. And those were one of the concerns that people had for instituting a law such as Death with Dignity, was whether they would be pressured by their family in terms of the burden on their family and also the financial burden on their family. And that's definitely not the case in our ALS cohort. And it also seems to not be the case in the overall cohort. In terms of what was the process of dying and what kind of medication they used, 50% of the patients used pentobarbital, 48% used secobarbital. The median time to reach unconsciousness was 4 minutes. The range was 1 to 60 minutes. The median time to passing away was 26.5 minutes in the Washington cohort, 30 minutes in the Oregon cohort. The range was 4 minutes to 26 hours. I don't know when that 26 hours was, but that was probably an earlier patient. All passed away when they used the medications, and none had complications, none regained consciousness. So the way that we do this, the way that we help our patients, it's safe. It results in what they want, and it also provides them with a sense of autonomy, because there's a significant number of patients who don't use medication. All right. So I think.
Excuse me, who wrote the prescriptions usually?
So they were pulmonologists, neuromuscular physicians that were in rehab, as well as neurology and general neurology. So spectrum of patients wrote the prescriptions. So the things that we can learn from this data, and hopefully what you learn, is that it's pretty boring. These patients are rare, and they tend to be reflective of the general Death with Dignity population. They tend to be white, richer, and well-educated, and well-supported by being married, and well-supported about being with their family. And we can also see that, and I think this is what I would call a success for ALS, and a success for what we're trying to achieve with this program. So in terms of patients who are enrolled in hospice, 91% of our patients were enrolled in hospice, and this is greater than the 85% in the all-cause population. And we were able to help 94% of our patients die at home. And that's pretty similar to the all-cause population, but I would say that, while this is a devastating disease, that we were able to achieve what our patients wanted. It was what we were doing. And I think that that could be counted as a success. So this is a lot of data, and I thought I would illustrate the case by showing a video of one of my patients who asked for the disease. And then what were your first symptoms that you noticed?
I couldn't get the glove on my hand, but I was doing some painting on my deck. It was hard to get the fingers in easily. And then I started getting fingers that would not stay straight. I'd get trigger fingers that started, and they would cramp up. Like I told you, when I saw you the last time, if I can't make my own cup of tea, I need to move on. And that's come back. I don't want to just sit in a wheelchair or the hospital bed and just be there. I already can't do anything except watch TV, which I love watching DVDs, but I need to move on. It's time to go do something else.
You scared?
I'm ready. I've been ready. My friends don't want to hear it, but I've been ready. I've had a great life. I don't have any regrets. I've done more things than most people have in their lifetime, with all my traveling, my dining, my friends, my teaching. I've given as much as I've got.
So some of my conclusions to my talk are the following. Typical ALS patients do not benefit from the addition of paraneoplastic testing. Riluzole may not help, and at most extends life by 3 months. FVC less than 50% is probably not the best predictive factor of dying in 6 months, and hopefully we can come up with a better scoring system. And patients have safely passed away under the Oregon and Washington Death with Dignity Acts. So in terms of some concluding thoughts, I think that since Lou Gehrig passed away, ALS is still a very devastating disease. And before we find a way to solve the disease or extend the disease, this is still a disease in which we as humans have probably met our match. And as we humans are not meant to live forever, we are all going to be in some way experience some sort of terminal disease, and probably something like this. Now, since 1941, we have improved our care for our patients with what Dr. Weiss talked about, with BiPAP, as well as G-tubes. We've been able to extend the life and improve the quality of life for our patients. And further treatment and finding better cures and better treatments are needed. But before we do that, before we are able to find better treatments, this disease remains for neurologists a test of how to be a doctor in its purest form, in terms of how do we comfort patients and how do we reduce their suffering.
And before we are able to find better treatments, I think that we should focus on how do we improve the care at the end of life? How do we measure the quality of care at the end of life? How do we make it better? And how do we communicate it better to the rest of the community? So those are some thoughts. I'm gonna finish up by acknowledging my collaborators, and I'll be open for questions. So here are my collaborators, and I'm really fortunate to have them. Michael Weiss, Jane Disdad, Najwa Al-Bustani, Josh Bendit, Susan Storm, Sharon Downing, Jen Vestrov, Paige Kayahan, and Elba Dorino Maldonado are people here at UW. Michael Elliott and Piper Paul are from Virginia Mason. Lee Young Henson from Swedish. John Ney worked on the project was me on Rilizol. In the PROACT database, we got help from Melanie Leitner and Neda Zach from Prize for Life, and Vivian Sue is the person that has helped us getting the Oregon data. So thank you for your attention. All right, Dr. Weiss.
Were there any particular religious groups that would not participate in this?
We don't have enough data. We don't have enough. We don't have enough patients to really know. And also the number of patients who have, well, first of all, Washington's probably one of the most religious states. I just read there's 22% of the population in the state of Washington claims that they're atheists, and that's more than the rest of the country. So the number of patients that are from different religious denominations are therefore much smaller already in our population. And the populations who asked for deaf as dignity is even smaller. And of that, a lot of them are just Christians or Catholic. Dr. Weiss?
Yeah, that was a really nice talk. Really enjoyed the slides in particular about the deaf dignity study. One question about that, and you and I have talked about this. So ALS patients are unique in regard to how they can enter into that, they can get involved with that or not get involved, because patients are supposed to be able to give themselves the drug. And so in a way, ALS patients could theoretically be discriminated against, because very often, very early in the disease, they're not able to, because they have such profound harm. So I guess the question is there any way to see if the patients with, I don't know if you have ALS FRSR data, I wonder if for any of these patients, but can you look at the subcategories? If we had it, we could look at subcategories and say, are there fewer patients with really low scores in those particular subcategories that focus on arm and being able to use one's arm? I think that would be a really, I would suspect that that's the case, that those patients would be underrepresented.
The question that Dr. Weiss asks is whether patients have problems using their arms and therefore cannot self-administer, and whether we can look and see in our database how many of them were affected. 100% of them had limb involvement. We can probably go back and look at the ALS-FRS, but the number of patients that we have ALS-FRS at around the time when they asked for prescription is definitely a much smaller population. So the number that we get might be a stretch in terms of what it really means. In terms of self-administration, the definition of self-administration is rather, it's not clearly defined in state law. And so compassionate choices are able to help patients. And what we try to do at the University of Washington, and I know at Virginia Mason, is that we try to identify patients before they are not able to self-administer. And I believe that in all our patients, they were all able to self-administer. The number of patients that were denied, I think that there were really only 2 that I know who who were denied. One went on to get the medication. Another one was denied, I believe, for frontal temporal dementia.
So to follow up on that, is it a requirement prescriptions have to be with pills or tablets?
The prescription is for pentobarbital, 10 or 9 grams, secobarbital, a large dose, and it's a lot of
There are
pills.
tablets that are different and then made into a slur.
Because just by coincidence,
Yes.
just by coincidence, this past Sunday's New York Times
Right.
magazine has a section on a lady who did her own death with dignity thing for dementia.
Right.
And her prescription was liquid, all liquid. I think it was pentobarbital, and that could easily have been done with a straw.
Right. So a lot of these patients,
The part of the issue though is that some of the patients are so impaired or Walmart,
Yeah.
they can't accept their straw. They have a feeding tube and they cannot administer.
self-administration through a G-tube is not prohibited under the law.
I mean, this should ultimately be about intent. Person is agreed to have full cognizance of what's going on. It should be about intent, even if the self-administration were some signal rendered by eye movement. That just seems to me a momentary glitch in this legislation. I did want to.
Well, can I repeat the question? Because I have a good way of repeating the question. Dr. Ransom thinks that we should all become Canadians like when I was born, because Canada has gotten it right and seems to state that for their law that's going to go into effect this summer, that is really about intent, and it's really not about how much time you have left. And that's the way that it respects that. And so I think that data like what we're trying to get together here will show that it's safe, and hopefully other places will be able to model that and try to improve on our law. But I don't really see that in our state or the state of Oregon that they're going to go revisit it. There was some idea that in the state of Oregon that they were going to take away the restriction of 6 months prognosis, but there was thought of doing that, but they decided not to do that, is what my understanding was. But I think that
I have another question, but Wen's question should come first.
I think your data, I would look at it and I would say that it is not possible to predict, right, when an ALS patient, or at least you can't predict the big one. And I think, the law is a really blunt instrument, and even the concept that there is predictability on that time frame should be lobbied against, right? Maybe we can't revisit the state death dignity laws, but maybe we should, as a neurology community, be lobbying against the idea of 6 months for hospice care, 6 months on the federal level for any sort of access to benefits. Because, I mean, ALS is just a perfect example, but there are many other examples in neurology where patients need end-of-life care, but there is no legitimate way to predict when that time frame is going to happen. If it's going to be 6 months or 8 months or 12 months or even 2 years, as your cohort suggests. So I don't know. I mean, I don't want you to stop doing what you want to do, but it seems sort of futile, this idea of coming up with a score. Looking at your data.
sure, agreed. Yes.
So how much leeway has a physician in this making up the estimate of 6 months?
So the question is how much leeway there is, and I think that all of us come with the best intentions and our best judgment, and hopefully none of us will be prosecuted for being wrong.
I think you just use the word likely, right? Too likely that it's
I mean, if the lawyer would say it's more probable than not the patient's gonna,
I like likely.
There's quite a bit of leeway.
yeah.
It's
To answer your question.
Your data seems to suggest that there is at least 100% error or uncertainty on the 6 months, if not more.
I don't
So
think it's.
if the physician uses the leeway, then they basically can extend in all practicality 6 months to a year.
I think,
How can they prosecute you if you make a mistake and the patient lives another year?
I think that they're unlikely to prosecute. I mean, I've had some patients end up in hospice for 3 years. I think half the hospice, they recognize that condition.
Sometimes they go off hospital.
Well, if they wanted to, or if they can go off hospice if they want some life-sustaining treatment. That happens to a patient who needs a peg tube. They'll go off hospice, they'll get the peg tube placed, and they can go back on the hospice.
I think that the law is, as presently constituted, really is just trying to make sure that the patients are safe and that they are able to ask for what they want. In terms of the prosecution, the federal government, through multiple Supreme Court cases, has not intervened, and therefore the state government has not intervened. I think that they basically leave it up to the best judgment of the patient as well as their physician. And I think that that's probably what the law was intended to do, was to provide autonomy to the patient and to protect and sanctify the physician-patient relationship. Dr. Distat.
Dr. Wang, thank you very much. I really was impressed with how you pulled all those different data points together. I want to clarify something as far as the issue with dementia. And I don't know, is there something within the, is there a specific evaluation that's required to determine whether or not?
So the question that Dr. Dissa asked is in terms of competency. And the competency is determined by two physicians, an attending physician who is the prescriber and a consulting physician who is the second physician. The two of them together can decide whether the patient has questions about competency or whether they have depression that's clouding their judgment, in which case then I can ask for a psychiatrist. In the Oregon population, it was about 2% of the patients were assessed by a psychiatrist. And for us, I believe it's 2 out of 39 patients we asked a psychiatrist to assess. But it's basically dependent on the prescribing physician and consulting physician to determine their competency and whether they're able to capably make decisions for themselves. The law states that, you know, you need to understand your prognosis, you need to understand your disease before you're able to ask for the medication.
And I guess again, that is also broad. So is there any specific mechanism, and maybe, you know, what have you done? Do you do any type of specific cognitive testing?
So the question is whether you do any cognitive testing. I feel as though, like an old-time neurologist, I just talked to the patient and I asked them, how long have you thought about this? What have you thought about? And a lot of times, you know, to answer conscious questions, the patients ask about it themselves, and they usually come from a very thoughtful place. The patients talk about, this is something that my family and I have discussed at the dinner table for the last 20 years. And unfortunately, this is the case of where I am at now, and therefore I want to do this. So just talking to it and just getting a narrative, you find out that a lot of patients have been really thoughtful and really are able to eloquently describe what they want. And so in my experience, there hasn't been really any time when you doubt their competency, because they're all really incredibly eloquent in terms of how they want it. And it's not really a rash decision.
So has had her hand up for a very long time.
Yeah,
Sorry. I have a question. How many of the patients in your death dignity cohort moved to Washington for this, or to Oregon, or to have that information?
So the question is, how many people moved to the state of Washington? So that was one of the concerns that the American Academy of Neurology had, was that people would move to Oregon to ask for death with dignity. And there was this really prominent case of this young lady who was cancer who came to Oregon to ask for it. In our cohort that I know about, 1 out of 39 was Canadian. And she came down from Canada. Her son was in the area. So to be able to establish residency in the state of Washington is rather easy.
Driver's license.
Dr. Ransom.
It's your turn.
So, nice job, Leo. That was really very thoughtful and good. I was fascinated by the work that you and your colleagues did on the paraneoplastic panel, and it highlights in my mind a huge problem. We spend a lot of time justifying very painstakingly whether a medicine works or doesn't work. We spend very little time justifying whether a test works or doesn't work. And all of us are guilty, I think, of saying, oh yeah, someone said we should get serum zinc on these patients because 1 in 7,000 patients might actually have an abnormal zinc content, which is potentially treatable. 1 in 8,000 patients was treated effectively. So we don't think a lot. We order these tests. They are a huge component of the budget-busting increase in healthcare costs. So we're at the brink of no longer having liberty to do everything we want to do. There will soon be, I don't know exactly how soon, strictures about what we can do. I think it's something that everybody has to incorporate and begin thinking about a lot more. What do you think?
I think that my approach is to try to address these questions like one test and one disease at a time. So I think that this is why you look at data, and this is why you try to look at this kind of information. And that's why we thought this would be useful to publish our paraneoplastic data. In terms of in other diseases, here at the University of Washington, we also have looked at the utility of paraneoplastic testing in CSF, CSF fluid, to see how useful that is. It turns out that in CSF fluid, just looking not at mental status changes, but just general tests of patients with ataxia or other things, that only 1 out of 44 CSF was positive for an antibody. And that antibody was anti-EO, and it was also positive in the serum. And so, that's definitely that we can save on 44 CSF tests, and that's something that we can bring up with the lab medicine people.
But I worry that things are viewed as useful until proven otherwise, as opposed to proven useful until where you first have to prove that they're useful before everybody orders it. I feel like the shoe's on the wrong foot.
Yeah, I think that your point about that we're ordering too many tests is a good point, but I feel as though we are also at a point where any test that we order is being questioned by the insurance company is probably not the best way to do things, where it's probably not the best utilization of my time or a clinician's time to defend every decision that we try to make. And a lot of times, I think that the way that I've been seeing about it in terms of my patients is that sometimes I'm treating the patient by ordering this test, that when they see that I have been thorough, they're able to accept the diagnosis. So even though it's negative, it is part of their process of grieving and their process of going through this to understand that nothing else can be done. This is what I have. And I find that that value is not capturable in terms of the dollars and cents, but I think that there is some value to the patient, and I don't want to deny that.